Thank you, Dr. Amrish, for the kind introduction. Thanks for all the attendees. I'm glad I made it on time. And this presentation has to be very quick because there are lots of things to say just in 10 minutes. So 2021 has seen many events, local and international, political, economic, the space level, at the level of the Earth. Many things happened in 2021. But what happened in cardiology? I'll talk about coronary intervention and valvular interventions. In the coronary, I'll talk about what happened in stents, in balloons, in atherectomy, in IVUS, in physiology, in left main, CTO, PCI versus CABG, dual antiplatelet therapy, and the guidelines. First, we'll start by stents. When you ask the question, what is the best stent? And the best stent in 2021, there was a nice comparison, a meta-analysis of more than 20,000 patients, 16 trials. They compared the thin strut stents with the standard stents. The thin struts less than 70 microns, and which we know here as the Orsero and the Biomime, and the comparison came in favor of the thinner strut stents. Target vessel lesion failure was less, target vessel failure was less, target revascularization was less. There was no difference in mortality or MI, but if you want the vessel to be patent and the stent at long time, then there may be an advantage for thin strut stents. Drug-eluting balloons, we use them frequently. We know from the baskets mold, it was in 2020, that they perform equal to drug-eluting stents when the vessel is 3 millimeters or less. But the good news is that in 2021, if you look at the diabetic patients less than 3 millimeters in diameter, drug-eluting balloons do more, they do better. If you look at the curve in red, this is drug-eluting stents in diabetics, and the curve in yellow is the drug-eluting balloons in diabetics. And drug-eluting balloons did better in terms of target vessel revascularization. You see a significant reduction. And this is the first time we see a device which is better than drug-eluting stents in diabetic patients. So drug-eluting balloons work best when the vessel is less than 3. Well, how do they do when in-stent restenosis, which we thought as the classic indication, not as good as we thought. This is a 10 randomized trials, a meta-analysis, close to 2,000 patients. In-stent restenosis to treat by another stent or a drug-eluting balloon. And when it comes to the efficacy, another stent is better. Again, there's no difference in mortality, there's no difference in MI, but if you need the vessel to be patent for a longer time, then it's another stent. Why? It's probably that as long as there is in-stent restenosis, there's lots of tissue, and the efficacy of delivering the drug through these tissues is not very favorable when there's lots of tissue in in-stent restenosis. How's atherectomy going? There was a recent publication that showed that atherectomy is growing in the United States. Not only rotational atherectomy, but also the newcomer, which is the orbital atherectomy. And what did that bring? What happens if we use atherectomy more? You see that as the number of atherectomy procedure increases, then we saw 3 changes. Number 1, in-hospital mortality is less. So this is the first time we see that atherectomy, just an observation, is associated with better mortality. That's the first thing. The second thing is that the PCI failure is less. So when you use atherectomy, the mortality is less, failure is less, but this comes at the cost of increasing the chances of perforation, which is, of course, must be dealt with. So is it for everyone? This is also an observation that correlates the relation between the volume of the operator, how many ablations he does every year, and the outcome. This is from the UK. And you see the clear that if you do less than 10 ablations every year, then the mortality rate will be high. If you do more than 40, then it's extremely good. But to maintain your program, then you need to be doing between 10 and 40 atherectomies every year. If you do below that, below 10, then probably your outcomes will not be good. Of course, the intravascular lithography is on the horizon, and we saw the publication of Disrupt CED3. It was just an observational trial that showed that the balloon is effective. It's success in more than 90% of the cases, and it's also safe. Imaging, does it work? We know that from the guidelines, IVUS is class 2 indication for left main and stent failure. How about lung lesions? This is a nice Korean study. It was a randomized study where they randomized patients who had lung stents, implanted more than 28 millimeter stents. and they were randomized to angiographic guidance versus imaging guidance. And they found that whether you look at 1 year or you look at 5 years, if you use IVUS, then there's the combined endpoint of mortality, revascularization is reduced by using IVUS. So what's the message here? We need to be doing more intracoronary imaging to optimize the results of our stents. How about FFR? We don't have long-term data, but we have short-term data. This is a nice study where they looked at procedures at the end of the procedure. The operator says, I'm done, the procedure is perfect. Then they did a physiologic assessment, and if they found a gradient, a focal gradient, they would treat by balloon or another stent. And the surprising curve was the first one, that pie chart. Even when you say that my procedure is perfect, I finished, let's go out of the lab, roughly 1/3 of patients will still have a significant drop, which is the one in red, FFR less than 0.8. Another 1/3 will have a gray zone. And surprisingly, it's not only diffuse disease. In more than 40% of patients, you will have either a focal lesion proximal to the stent or distal to the stent, or the stent needs to be optimized. What happens if you adopt this protocol? The panel in D, the end result is that you have less patients with a significant gradient at the end of the procedure. Does that affect the long-term outcome? We still don't know. But there is another gadget which is frequently now available in cath labs, which is the QFR. It's a non-invasive, it doesn't need a wire inside. And there was a Chinese trial that was published also last year in Lancet, and they showed that if you guide the procedure by QFR, then you get a significant reduction in endpoints at 1 year if you guide the procedure with angiography. So probably this technology is here to stay. Now probably the most important publication at all. No, not this one. We'll take the next one. Looking at those patients with multi-vessel disease, whom we can revascularize by PCI and we can revascularize by CABG. We know from the earlier Syntax trial that CABG has an advantage in patients with multi-vessel disease. Now, there was another trial, it was not a randomized trial, but it was an observational trial, it was the Syntax 2. And what they looked at the performance of state-of-the-art PCI. Good operators, but not only other operators. FFR was mandatory. You didn't treat any lesion, you had to treat the one which is physiologically significant. IVUS was mandatory, the thin strut stent was mandatory, and dual antiplatelet therapy for 6 months was mandatory. And they compared the outcome when you do this, when you stick to this protocol, versus the initial Syntax trial. And you can see there's almost a 46% reduction in major adverse cardiac events if you use IVUS, if you use FFR, if you use thin drug eluting stents. Now in STEMI with multi-vessel disease, you have a borderline lesion. Would you do FFR to assess that, or you just count on angiography? FFR failed, you just count on angiography. There's no significant difference of doing FFR in the setting of acute MI to defer a borderline lesion. Why does that happen? Because probably this trial showed that if you look at borderline lesions, whether acute coronary syndrome or not, in the group which is have a FFR of more than 0.8. I have to use the pointer. Look at this group, FFR more than 0.8. And you do an imaging with OCT. And you have two kinds of plaques, a thin cap fibroatheroma and a fibrotic cap. And if you follow the atheromas that are thin cap, then the chances of having events are more than 6 times or 5 times compared to those lesions that didn't have a fibroatheroma. So maybe, this is my suggestion, if you want to defer a lesion in the setting of acute coronary syndrome, you need to do imaging first and make sure that it is not a thin cap fibroatheroma. What happened in left main, there was an important trial, which is the European Bifurcation Club trial on left main, and they here randomized patients with simple left main. It was not complex left mains. They randomized them to provisional strategy versus a double stent strategy upfront. And in simple left mains, there's no difference between a provisional versus 2-stent strategy. And there was a nice accompanying editorial that showed in simple left mains, it's provisional. In complex left mains, you have to go for 2-stent strategy. 2 important CTO trials that talked about definition. Now the terminology of CTO is changing. There's no talk anymore about intimal or subintimal or subadventitious. This has changed. Now we're talking either intraplaque or extraplaque. The other one is the definition. What defines an MI after a CTO intervention? You need elevation of the troponin more than 70 times. I will not go into the algorithm. What to do about dual antiplatelet therapy? This is the first trial that showed you can do unguided de-escalation from ticagrelor to clopidogrel, and there is no change in the outcome. There were previous recommendations of de-escalation based on genetic testing or on platelet reactivity testing, and they showed that you can de-escalate based on two. But this is the first trial that showed even without genetic testing, even without platelet reactivity testing, if you de-escalate in the stable patients after 1 month, then there will be no difference in outcome. Of course, now everyone is going towards short dual antiplatelet therapy, and the meta-analysis showed that if you lower the duration, shorten the duration of dual antiplatelet therapy just to 1 month, and continue either on aspirin or on a P2Y12 inhibitor, then bleeding is much less, and there's no increase in death or MI. There is a slight signal of more stent thrombosis, but it's not statistically significant. The funny news about the new guidelines for myocardial revascularization published by the ACC-AHA, they were accepted by cardiologists, but the surgeons complained about it. They were not happy about it because of many reasons. The surgeons were not happy about downgrading of CABG. Now, CABG in multivessel disease with a normal ejection fraction gets class 2B, and the surgeons were worried that there would be problems with reimbursing procedures that are class 2B. So, and they sent this famous letter, and they published in the European Journal of Cardiothoracic Surgery why we're not endorsing the cardiology guidelines. So now we're seeing a divide between cardiology and cardiac surgeons. We're not seeing the same divide in the valvular field. Both the surgeons and the cardiologists endorsed. If you have a patient with aortic stenosis, referring to surgical or transcutaneous valve implantation is based mostly on the age, and the cutoff is 75. Patients younger than 75, they get a surgical valve. Older than 75, they can go for TAVR. And for the first time in the guidelines, we see a class 2B indication for percutaneous tricuspid valve repair, which is on the horizon. Is there a difference between surgical replacement and transcutaneous replacement in low-risk individuals? There's no difference in the long term. Other pieces of news, core valve is similar to Edward Sapien, but Accurate Neo fell behind because of high mortality and high paravalvular regurgitation. Cerebral protection devices don't work. The best anticoagulation strategy after TAVR is not dual antiplatelet, it's not NOAC, it's just single antiplatelet therapy. That's all, and thank you so much.